You're filming?
Yes, I'm filming.
Okay, it's a good thing I got a haircut.
I thought you did it for shooting.
No. Anyway, so the main indications of we're going to discuss pericardiocentesis. The main indications, of course, is tamponade in the setting we're in. Sometimes you do it for a very large pericardial effusion without tamponade, but that's not what we're going to be doing. We do it for people, emergency tamponade. A lot of the procedures we do can result in perforation and rapid accumulation of fluid. It doesn't take much, 150, 200 cc's of blood, that's enough to cause tamponade. So this is a tray, it comes with all the stuff we need. Different operators have different preferences. I like a little different things, but the stuff that's here is, for the most part, everything that's required. A peri-vac kit, I think they call it here. So everything in here is sterile. We're not going to maintain sterility, obviously, for this technique. The first thing on top of here, this bag, that's for later. You have to save it. But it's important to know about this bag a little bit because I've seen some mistakes, not here in this lab, but on other places. It's graded so you can know how much is accumulating, and it starts at 100 cc's and it goes up to a liter. The end here is that there's a drain so you can empty what's accumulating. There's a little cap on the drain there. But it comes open, so if you don't close it, the drain starts pouring out. So that's the one thing I would say, that, you know, when you're doing it, just make sure you close it so that it locks it in place. This end here is the end that's going to be given to the physician to connect to the actual drain itself. Then there's a fenestrated sheath. So there's a sheath here that sterile and has a window. In an emergency situation, I mean, sometimes there's no time for anything. I guess this is not fenestrated, I thought it would be. But sometimes there isn't time for anything. But if you have time, which you should try to do, you should at the very least try to sterilize the area. And the area we're talking about is subxiphoid. So I'm not going to take my shirt off for this demonstration, but
You may.
but you look at the ribs where they join, and the xiphoid process is right in the middle. And if you imagine that my finger is the xiphoid process and this is the rib, there's a little triangle that forms, and that's the angle where you go in. And so this area, the whole area right between the ribs and the xiphoid process, needs to be prepped. Wide, extensive. It's important. This, I guess, is the fenestrated sheath. So that's just a sheath that you cover other things. This is a fenestrated sheath that comes into place. Some physicians, like me, for example, I like to be the one that puts this on. Like, you can put it on for me, but as long as you don't take off the sticker, because there's a sticker on the other side. Because if you peel off the sticker and put it down, then I won't be able to move it. But you can put it on, and then when you find the spot that you like, you remove the sticker and you put it in place. It's not such a big hole, but it provides a good field of sterility there. But so for the first couple of things that I removed need to be out of the way. This is to prep the chest, and for the most part we don't prep with this. We have ChloraPrep or whatever else we use, DuraPrep, but you can use this if you wanted to, and that's why it's here, but we don't really use it too much. Alright, so this is the real important stuff. This we don't use a lot anymore. It's of historical value for the most part. And what this is you would connect this to an EKG and connect it to the needle. And as you were going in, if you saw on the EKG a sharp injury current, like an ST elevation, you were at the myocardium, you were gone too far, you got to pull back a little bit.
Why don't we use it then?
Because we've gotten a lot more experience these days, and usually when we are doing this procedure, there's so much fluid accumulating that there's a big space of fluid. And so there you have a lot of room before you go too far. If you're doing it for a dry like if there's very little fluid, it might be reasonable because you don't want to go in too far. But for the most part, when we're doing it in an emergency, there's a lot of fluid, and basically the pericardium separates. If my fist is a heart, the pericardium will separate. And so there's a whole space in there. Even if you go a little too far, a little bit less, you'll get it. But if there's only a little bit of fluid, then there's a little space. Sometimes this is reasonable, but we don't do it too much anymore. What has replaced this for the most part is echo guided. Sometimes we use an echo, and on the direct ultrasound we see it. All right, so the next thing we do is, let me just show you what these things are. This wire that comes with it, notice that there's a J tip. This applies for every wire. Whenever you hand off a wire, it's nice if you bring this introducer out here, because this wire has to go into, and I'll show you later, but this wire has to go into a dilator, for example, and the physician can grab it and stretch it open, but it's nicer and it's faster if it's already at the tip. That way when it goes in, there's no, well, not that time. But when it goes in, there's no fumbling and you just go in. All right, so this is a dilator, and I'll show you what that's about. This is a needle, and it's a special needle. I'm going to remove this plastic guard here. It's a special needle because, first of all, it's very long, right? And secondly, it has a trocar here. And this is important because you're going through, when you're doing this stick, you're going through a lot of fat here, you're going through diaphragm, and then you go into the heart. So you don't want all that stuff, fat and diaphragm and all that stuff to enter this and plug up this needle. So this trocar is always there inside. You don't remove this, and it plugs up the needle so that this is a solid piece of metal going in. It doesn't take anything into the needle, nothing gets obstructed. And then when you think you're in proper place, then you remove this and check. All right, this is the sheath itself. Special sheath also because you can see, I don't know how good you can see, but there are holes along the sheath. It's not just the tip. Obviously the tip has a hole, but along about 4 centimeters, there's a hole, another hole, there's about 8 holes here. And this is good because it allows for rapid removal of fluid. This is the most common sheath. It's pretty soft. It's hard to hurt anything with it. I like, and a lot of people like, the pigtail sheaths. We don't always do it, but it's nice because the end is curled, and that way you really can't hurt anything because there's no point at the end. It's all just curled. But you don't have to. This comes with this, and this is fine. Now, they're just extra 4x4s. These are needles for local. In the cases that we do, we don't mess around with this small, tiny needle. This is good for when someone's wide awake and you want to be really nice and start with the skin for numbing. We usually go straight for this needle, numb up the area, and sometimes we don't even have time to numb. But you numb up the area, and then the next thing that we do, different people do it different ways. The next thing that I do is when I locate the area that I want, if this is the area I want to go into, and I've already numbed it up, then I make a cut. Not everyone does it this way. Some people go for the stick with the needle straight away. I make a cut now. I point out where I want to go, and I make a cut. I just jab it. And this frees up, this makes it softer so that when my needle goes in, it doesn't, I don't have to go against resistance of the skin. So then I go into the same area that I made the little cut. I really can't see it here. But you go into the same area. And this is the thing, we direct it under fluoroscopy. So in an emergency, sometimes you don't even have that choice. But if you have x-ray, you angle the camera to an LAO view, and I'm going to show you my skin. Basically what I'm trying to do, this is the angle. This is the rib here, and this is my xiphoid process. I'm entering here. And the way I enter it, if you look at the angle with the skin, you enter it kind of like at a 30-degree angle or so, 20-degree angle. It's not that flat. You got to get under the rib. So you have to get under the rib. But also, if you go too perpendicular, you're going to miss the heart. You're going to go just to the lung. So it's got to be in between. You're kind of pointing to the right shoulder. So in this angle, it's not straight up. You're kind of pointing to the left shoulder, sorry. You're kind of pointing to the left shoulder. And in this angle, there's a little, it's like 20 or 30-degree angle. It varies a little bit. You go in, bevel up, like we know for other things. And you're going in under x-ray guidance. You're in an LAO view. And so you're seeing the heart. And when the needle gets close to the heart, you don't rely on what you're seeing. Yes, you're looking for the needle getting close to the heart, but it's a little bit unreliable because of the plane. Sometimes you're in a different plane and you can look like you're at the heart, but you're not really at the heart. But what you do is you feel, there's a point where you feel a little pop. You feel like a little resistance bend, and you can almost hear it, but you don't really hear it, you feel it. And at that point, you remove the trocar in here, and you check. You check with I'll use another one, it's okay. You check with, this one is best. This one is best. It's bigger, and then you just check to see if there's blood coming back. And there should be. And if there is blood coming back, you may think that you're in the pericardium, but the big problem that you could have caused is you could have gone into the heart, and obviously you're going to get blood there too. So you have to be certain you're not in the heart. There are different ways to do that. Different people do different things. Some people put in contrast. So you put in contrast, and if you see it's in the heart, then obviously you've gone in too far. If it's outside the heart, you're in the right spot. I like to, and that's a great technique, putting in contrast is great, because then the other thing you can do is you keep pulling until you see no more contrast. Because your contrast is in the pericardial space, you keep withdrawing until you see no more contrast. What I like to do, I like to use a longer wire. I like to use a longer wire than this. This is, I don't know how much this is. This is like 40 centimeters.
Woolly, right?
Yeah, I like to use a woolly,
Okay.
because I keep pushing the woolly in. And what that does is, if you're in the pericardial space, the woolly wraps around the entire heart. Because if you're inside the heart, you're contained in a cavity, either in the left ventricle or the right ventricle. There's no way you're going to be able to go around the entire heart if you're inside the heart, because there are walls. So what I like to do is I like to put a Woolly all the way in and make certain that it's wrapped around the heart, and that way I know that I'm outside the heart. Why is that important? Because you don't want to do that. You can stick the heart with a needle and it'll heal. If you've got in the heart, you just pull out, it'll heal just fine. What you don't want to do is put this bad boy in the heart, because this is very thick. So once you confirm that you're in the heart, then you keep the needle in place. You put once you confirm you're in the heart with a wire, now we're not dealing with the needle anymore, because what we did is we had a needle. Let me just fix this. We had a needle. We insert this wire that comes with the kit. Like I said, I like to use another wire, but you can use this one. So this is going into the heart, or around the heart rather, right? So this is somewhere inside around the heart. Then this is at the skin, the needle. It comes out, the wire stays in place. Then the dilator, you have to hand the dilator next, because there's a lot of resistance, there's a lot of tissue, and this is pretty soft, it's not gonna make it. This is a stiff dilator, and the dilator goes over the wire, outside the body. This is, let's pretend that this border here is where the skin is, this edge of this white thing. So this is outside the body, and you feed it over the wire. You never lose the wire. Just like anything else, you can't pull back. That's a big problem. You don't ever pull. Just let the doctor hold it, and you advance this. And when you see the wire, you can hold it, but you can hold it for the doctor. Sometimes they'll say, can you hold it as a rail? That means just hold it firm. Don't pull, don't push, just hold it. And that way, when you're holding it, this can be advanced. And basically, you advance it back and forth a couple times along the area of resistance. Now you made a nice tract with this. And you don't want to do that if you're in the heart. So that's why the first step is very important. Then this comes out. And now you can get your actual sheath in place. This is their pericardial drain. And this is the one that has all the holes in it. So it goes in. Again, and this should be easy, because now it's going along the track of the dilator that you did. And you put it in. You put it in all the way, and you're looking under x-ray. You never want to lose the wire. This always has to be, somebody always has to see wire before you can advance. So you're advancing over the wire, and then once you think you're in place, you pull the wire out. This is in place. You confirm, you take a syringe, you confirm that you're actually in the right spot. You pull out, it should come out freely. Obviously, the other thing I didn't talk to you about is rarely are you going to see bright red blood there. I mean, sometimes in coronary perfs you're going to see bright red blood, but for most procedures it's going to be RV perfs, and then you're going to see darker blood like venous blood. You confirm that this is good, and what we do is, at this point, once you confirm that you're in a good position, you attach the three-way stopcock to this bag. And what I like to do, it doesn't come with the kit, but we like 60 cc syringes to be available, because this is only 20 cc's and you're going to be pulling back a lot. 60 cc's are nice to be present. Then you attach this three-way stopcock to the long end, not the draining end, to the long end of the bag. And then this gets attached to the sheath. And so you have a three-way stopcock, and what you do is, actually, I attached this incorrectly. Yeah, I attached it incorrectly. I like this to come off the side, because I think it's easier to pull when it's straight. So this syringe goes here. And so this is locked to the bag, and I pull out, then I seal to the patient, and I push to the bag. Then I, again, lock to the bag, pull out, seal to the patient, push to the bag. And you keep doing that until there's nothing coming out. If you put contrast in the way some people do, you keep doing it until all the contrast is gone, because there should be no contrast in the pericardial space. And that's nice, that's why it's a nice technique. What I do is, once, at some point you see the heart border start moving, the pressure should get better, everything's getting better. Then the question is there reaccumulation? Because sometimes you keep pulling on and you have 400 cc's, 500 cc's. At some point, is it going to stop? Because if it doesn't stop, a lot of times our patients are anticoagulated. Obviously, one of the first steps is to reverse that with protamine. But if it doesn't stop bleeding, sometimes you have to call the OR. Sometimes you have to be rushed to the OR to close up whatever hole. But most holes will seal. Most perfs will seal. And so, not everybody does this, but something I like to do is when it stops bleeding a little bit, I pull, and you start feeling resistance, because at some point this is up against solid tissue. And there's a little vacuum there. There's nothing to take. So you start pulling, and it's not easy to pull anymore. There's resistance. So when I feel the resistance of a vacuum that I created, I close off to the patient, and I have like negative pressure in there because I created a little vacuum. And that, in theory, sucks in the pericardium against the heart and helps to contain whatever perforation. And I leave that there for like 5 or 10 minutes while I'm doing whatever else. You're looking at the cardiac border, you're seeing that it's moving, the pressure's getting better, you call an echo, you make sure there's no more effusion. You probably already had an echo, honestly, at this point. Unless you really strongly suspect there's effusion, sometimes it's in between, you call an echo to confirm. So you confirm that there's no more effusion. And then another important question is, do you leave this drain in or not? If it's a quick thing that you know where you caused the perforation, there's no big anticoagulation, it stopped bleeding pretty easily, the patient's pretty stable, often we just pull this drain. The reason is, this is irritating. So this is irritating inside the heart, it hurts, it's plastic. Every time you breathe, it moves. And even though it's soft, there's a tip to it. And so it hurts a little bit. And that irritation can cause inflammation, can cause more fluid to accumulate. Even if there's no more perf, you get more fluid accumulating. And it's painful. So sometimes we remove this. There are differences. Some people inject steroids into here before removing it. I don't. Some people do. Some people inject a little saline before they remove it to kind of flush out. They don't like leaving blood around the heart. So they inject saline and they kind of flush it out until it's clear. That's interesting too, because blood is irritating. I don't necessarily do that, but there's nothing wrong with that. If you pull the drain out, then you should be all done. Some people leave it in place, and in that case, you can leave it just as is, open, closed to the third port here, and open to drain. And then you'll just accumulate. This usually goes to gravity, and then that's it. And then hopefully you save a life. And that's all.
Okay, thank
All
you
right.
very much.
You're welcome.